here today. Dr. Jacqueline French is a professor of neurology in the Comprehensive Epilepsy Center at NYU Langone School of Medicine and founder and director of the Epilepsy Study Consortium, an academic group that has performed a number of early phase clinical trials in epilepsy and has developed new methodologies for epilepsy trials. Dr. French trained in neurology at Mount Sinai Hospital in New York and did her fellowship training in EEG and epilepsy at Mount Sinai Hospital, as well as Yale University. Dr. French has focused her research efforts on development of new therapeutics for epilepsy and new methodologies for clinical trials. Over the past 20 years, she has served as the principal investigator on a number of trials for new epilepsy drugs. She is responsible for the creation of a number of new trial designs that have been accepted by regulatory authorities for new drug approval. Dr. French has been active in creating guidelines for the American Academy of Neurology and the International League Against Epilepsy, which is the ILAE. She chaired an AAN and an AES committee that produced two widely quoted guidelines of the use of new anti-epileptic drugs. She has served as chair of the International League Against Epilepsy North American Regional Commission and Commission on Therapeutic Strategies. Dr. French serves as the Chief Medical and Innovation Officer at the Epilepsy Foundation of America. She is the past president of the American Epilepsy Society. She is the past secretary of the American Society of Experimental Neurotherapeutics. She is the recipient of the American Epilepsy Society Lennox Award and Service Award, the Epilepsy Foundation Hero Award, and is an ILAE ambassador for epilepsy. She has authored over 300 articles and chapters, is the editor of 3 books, and lectures internationally on clinical trials and use of anti-epileptic drugs.
Now I'm tired.
We're so honored that you're taking the time to share all this wealth of knowledge with us here in Hawaii.
And because we're such a small group, just shout out if you have any questions. Don't be shy. Don't be shy. All right. So here are my disclosures because with all of that you just heard, I work with the Epilepsy Study Consortium that tries to bring new therapies to the clinic. Just today, believe it or not, I talked to 2 new companies in the epilepsy space. So I talked to lots and lots of companies, and they're all very interested in epilepsy, I'm happy to say.
Yay.
Yay, yay. So just to get you grounded in what we're talking about, the way we classify epilepsy right now is we classify it by where the seizures start, and then below that, what syndromes people have. So the most common epilepsy is focal epilepsy. That's where somebody has a little spot in the brain where the seizures are coming from. And the seizures can spread from that spot. So if somebody has a brain injury or a tumor, or they've had a stroke, or sometimes they have some electrical disturbance in one spot in their head and we don't know why that is. But that's called focal epilepsy. And the type of seizures people have with that are focal aware, where they feel something, but they don't lose awareness, focal impaired aware, and focal to bilateral tonic-clonic, which is a convulsion. And then there's the group that's called the generalized. They have generalized seizures. That's where the whole brain is a little bit hyperexcitable and it all charges off at once. And this is almost always a genetic epilepsy, although we don't know the gene that causes it, but we know that it's genetic because it runs in families. And you'll recognize perhaps some of the names of the syndromes, juvenile myoclonic epilepsy, absence epilepsy, etc. The seizure types here are absence, myoclonus, and generalized tonic-clonic convulsions. And the reason that it's important to know which group you fall in is because our treatments pretty much follow these categories as well. Treatments for focal epilepsy, treatments for generalized epilepsy. And then there's this group that's a combined generalized and focal. And that's, usually starts in early childhood, is associated with delay of development or profound mental retardation sometimes, other kinds of handicaps. many seizures a day, different kinds of seizures, and the brain is so hyperexcitable that it can either all fire off at once in a generalized way, or little pieces can fire off in a focal way. So that's why we call it combined focal and generalized. And another name that we call that group is developmental and epileptic encephalopathy, because their brain does not function right. And there's seizures on top of that. And some of the names of the seizure syndromes within there are Dravet syndrome, Lennox-Gastaut syndrome, many other syndromes. And the number of children that have each of these syndromes tends to be small. And so when there are rare populations within syndromes, we call those orphan diseases. The definition in the United States of an orphan disease is less than 200,000 people in the country who have had that condition. So the generalized and focal epilepsies tend to be a basket of orphan diseases of different kinds. And then, of course, there are some that we don't know where their seizures start. Now, a very important concept for 2020 and beyond is that we are getting more honest about how we name our drugs. So as a class, we used to call them anti-epileptic drugs, but hey, they actually don't treat epilepsy. They treat the symptom of seizure. So we are changing the name to anti-seizure medicine, hoping that in the future we have another category that actually is anti-epilepsy or disease modifying in some way. So I saw some head nods, but just to give you the example, this little guy with pneumonia, he, if we treated his pneumonia, that would be modifying his disease. But if we only treat his cough, that is only treating the symptom. And the anti-seizure medicine is like treating the cough. And the consequence of that is that the pneumonia still remains, the seizure disorder still remains. And so you have to keep giving that medicine forever as long as that seizure disorder remains. We sure would like to get rid of the seizure disorder eventually, and it will be coming. Generally, when you talk about treatment with drugs, the first drug that we try in people will get about half of people seizure free. So that's not bad. Even people who are having lots of seizures still have a good chance of responding to the first drug we ever give them. The second drug, we can get about another 10 to 15% seizure free. But when you failed the second drug, then things start to look a little grim for you. The third drug, only 1%, and then lots of different combinations, whatever, and maybe another 3%. So overall, when you look at a population over time with all kinds of epilepsy mixed together, all the different syndromes I talked about, we're talking about an average about 2/3 of them becoming seizure free, and about 1/3 of them to 40% being what we call treatment resistant, meaning they've passed that second drug mark. And, that goes to, do we need more epilepsy therapies? Well, I think you guys know the answer to that. But, we get 60% seizure free, but 40% we don't. And new anti-seizure medicines that have been introduced over the last 20 years haven't really changed that for us. And in addition, even the people who are seizure free sometimes have side effects that impact their quality of life. And therefore, we need not only drugs that control seizures, but drugs that control seizures without the safety and side effect issues that we have to face. So sort of going back to where I was before, start out with single drug therapy. If that doesn't work, probably try some combination therapy. And if that doesn't work, then you fall into this category of treatment-resistant epilepsy. And if you do, then there are still some things that we can do for you. We can try the ketogenic diet. This is mostly for children, but it is for various kinds of epilepsy. But the younger you are, the more likely you are to respond to the ketogenic diet. You can have some diets in adulthood. but they're not as likely to be successful. We have the low glycemic diet like South Beach we can do, or the modified Atkins diet, but they're not that successful in adults. You can do the vagus nerve stimulator. That is potentially successful no matter what kind of epilepsy you have. Then there's some things that really you have to have a seizure focus. You have to have focal epilepsy to be a candidate, including stimulators that are implanted in the head, including the responsive neurostimulator and the deep brain stimulator. Cutting out the seizure focus with an epilepsy surgery if that location of the focus can be found. And that can definitely be disease modifying. It can lead to no more seizures, and problem solved if one can find the right part of the brain to remove that has the seizure focus in it. There is a less invasive technique now called laser ablation, where you basically burn out the focus. And finally, you can continue to try different anti-seizure medicines. So going into a little more detail on the laser, because that is a new therapy that we have more recently. In order to do that therapy, you don't have to go to the operating room. It's just a probe that's placed through like this, that's placed through a small hole in the skull that gets drilled. And then using an imaging technique called MRI, you place that where you think the seizure focus is, and then you heat up the tip and you basically destroy the seizure focus that way. It is used for epilepsy associated either with a lesion or temporal lobe epilepsy, where you know that you're trying to hit the hippocampus, which is this area of the brain in the temporal lobe. It usually only requires an overnight hospital stay as opposed to actually cutting out a piece of brain, which is a much more involved and more dangerous procedure. Unfortunately, particularly when you're looking at temporal lobe epilepsy, the rates of seizure freedom are slightly lower, so there's a trade-off there. But a lot of times people say, well, go for the less invasive first. If that doesn't work, we can still go and get the open surgery. The safety definitely seems better, but it's early days and we're accumulating more and more information about this. But it's a very nice option for people who don't want to go and get their head cracked open, as they say. So this is laser ablation down here. We have the deep brain stimulator and the responsive neurostimulator. The deep brain stimulator, you don't have to know where the seizure focus is, but so far it's only been tested in people with a focus. These electrodes get put in a deep part of the brain called the thalamus, and they just go off on a schedule every 3 minutes or every 5 minutes. Whereas the responsive neurostimulator is a little different. You do have to know where the focus is. You put an electrode at or near where the focus is, and when a seizure tries to start, it tries to countershock to prevent that seizure from exploding and causing a clinical event. So both or all, when you talk about vagus nerve stimulator or these two implantable stimulators, they may act by mechanisms that are distinct from other epilepsy therapies. We think of epilepsy as not only a focus disease, but a network disease. Somehow, different nodes in the brain don't talk to each other correctly, and we may be sort of disrupting abnormal networks, changing seizure dynamics. We really don't know exactly how they work. Having a stimulator approach avoids the side effects of medication. A stimulator is not going to make you sleepy. It's not going to make you have difficulty concentrating or difficulty sleeping or things like that. The implantation itself can have some risk, though. You could have a bleed or you could have an infection. But if you get past that surgical implantation, then you're probably going to be fine. And most people don't know that the stimulator is going on and off. Unlike the vagus nerve stimulator, where everybody feels it each time it goes off, these stimulators, you don't feel as they go on and off. So once it's in, you're past the surgery, you're good to go. And most people keep them in for quite a long time. It typically improves seizures, but unfortunately for most people, it is not a cure. Only a small percent over time may have complete control of their seizures, unfortunately, but it is, successful. It's helpful in reducing seizures severity and frequency. And again, the responsive neurostimulator, you do have to know where the focus is. The deep brain stimulator, you don't. So we have had a lot of seizure medicines approved over the last 25 years or so. Believe it or not, when I started in this business, because I'm old, only the drugs in gold here were available, and all of these other drugs were approved in my lifetime for sure as an epileptologist. The last two in the last 12 months were cenobamate and fenfluramine. So I'm going to go into a little more detail on those. Just to show you that we have, things have switched around a little bit from the early days of this flood of new treatments to after 2008. That was sort of like the dividing line. At about 2008, whereas before 2008, the drugs that were approved were almost all approved for focal seizures, which again is the most common seizure type. The market got a little flooded with treatments for focal seizures, and people started to think about the other unmet need, which was the rare epilepsies in that combined focal and generalized epileptic encephalopathy group. So you can see in green all of the therapies since 2008, more than half have been approved for those types of syndromes: Dravet syndrome, Lennox-Gastaut syndrome, infantile spasms, and so on. Although there have been a few still that have been approved for focal seizures, and one that also got an approval for primary generalized tonic-clonic seizures. So I'm going to go into more detail on the most recent focal epilepsy drug because I think it bears discussing, and that is a drug known as cenobamate. The trade name is Xcopri. You guys did the trials for that, I presume? Yes, thumbs up. And so I'm sure you have some successes with it as well, and I do as well. But when you look at the results overall, I showed you that when people had failed a couple of drugs, the likelihood of success was about 1 to 3%. This drug sort of breaks that mold, which is really nice to see. So I personally have people who are long-term seizure-free on this drug, and many investigators do. And these are the results from the larger phase 3 studies. And what do these dots mean? So first of all, this bottom line here is the sugar pill or placebo. So these studies are done where you have 3 months where you're tracking people's seizures. You're comparing it to before they took the drug. And you're seeing whether adding on, not exchanging, but adding on either a sugar pill or placebo, or a low dose, medium dose, or high dose of the drug, in this case cenobamate, makes people's seizures better. And this actually just shows you how many people, what percent of the population had no seizures in the 4 weeks prior to the dot. So this is weeks 1 to 4 of the study, 5 to 8, 9 to 12, 13 to 16, and 15 to 18. The first dots, the patients were still titrating up on the dose, so they didn't get the full effect. But by the time they were up on their dose, their maintenance dose, you can see at the highest dose, 30% of the patients had not had a seizure in the previous 4 weeks. And these are patients who had to be having at least 3 seizures a month to get into the study, and the median, or the midway point, was about 9 seizures a month. So they were having a lot of seizures. And that really maintained somewhat lower for the middle dose and somewhat lower for the 100 milligram dose. But when you add it all up and you look at how many people were able to stay seizure free for all 3 months, It was only 1% on the placebo, so there was some bouncing up and down. It's not the same people for this 4 weeks as this 4 weeks as this 4 weeks, so only 1% were seizure-free throughout, compared to 4% on 100 milligrams, 11% on 200 milligrams, and fully a fifth of the population were seizure-free for the entire 3 months of the maintenance on the highest dose. So that was the good. There's a little bit of bad news to go with the good news. So the good news is that it worked really well in the trials and got a lot of people seizure-free, at least short-term. And it was very well tolerated up to the 200 milligram or middle dose. After the 200 milligrams, going up to the 400 milligrams, some people did have some trouble tolerating it. I found personally that if you took some medication away, some of their background medication, they could tolerate the higher dose better. The bad news is that in those first trials, there were some people who had a serious rash, and particularly something called DRESS, which is drug rash with eosinophilia and systemic symptoms, which is a very serious rash that can sometimes be fatal and or land people in the hospital. So because of that, the FDA required the company to go back and do another just purely safety study. And they tried something that they've done with other drugs, which is that if you expose the body just very slowly, then sometimes when the body gets used to it, there's less rash and less, reaction. So they slowed down the ramp up to 8 weeks to get to the target dose, which is pretty slow. And they did about 1,300 people that way, and there was nobody with a serious rash. So certainly there was far less serious rash with a slow ramp up. And we're just going to have to look in a larger population now as the drug is available. But I still think that it's, with the slow ramp up, it's very well worth trying for people who have not had their seizures controlled. Now I'm going to move on to a drug for the other group, which is the orphan developmental and epileptic encephalopathy group. And I'm going to talk about fenfluramine. So fenfluramine may or may not sound like a familiar name drug to you, but maybe you've heard of a drug called fen-phen. And fen-phen was a drug in the 1980s that was put on the market to make people lose weight. It actually was pretty effective at that. But unfortunately, after people were very happy about shedding a bunch of pounds, it turned out that the drug was very dangerous because in a small percent of people, it caused their lungs to fibrose or it caused their heart valves to thicken. And some of those were very serious consequences. So the drug was pulled off the market. But at the time, at that time in the 80s, fenfluramine alone, not the fen-phen, because fen-phen is fenfluramine and phentermine combined together. This was just fenfluramine, was being tested in a small group of kids with Dravet syndrome, which is one of the epileptic encephalopathies, very severe epilepsy in young children that is genetic in nature. And those kids did very well, and they were being followed for literally decades. So at that point, somebody said, hey, let's put this drug into clinical trials. Let's see if this is going to be if this is going to work for the majority of children. And indeed, it turns out that it did. So this is actually a low dose of fenfluramine. What was in the fen-phen was a much higher dose. And you can see that 70% of the kids at the higher dose, this is still not a high dose, but a higher dose, had their seizures cut in half during the study, and 45% at the higher dose had their seizures cut by 3/4. So that's pretty good. And if you look at the drugs that are available for Dravet before fenfluramine, they could not get anywhere near this kind of seizure control. So kids are doing really well on it. Again, the good and the bad. We are still observing kids, and they have to go and get ultrasounds of their heart at intervals in order to make sure that there's no heart valve thickening, but we haven't seen it yet. So we're optimistic that hopefully at this low dose, we're not going to see it. And as far as other serious emergent adverse events, there really was not more in the treated group than in the placebo group. So that is good to see. So I just want to change gears and say that advances in therapy are not just addition of new anti-seizure medicines and anti-seizure devices. Sometimes they can be other things, rescue therapies, devices to forecast seizures, learning better to use the drugs we already have, and the future disease modification. So starting with a rescue therapy, what is a rescue therapy? A treatment that isn't given every day, but is given at times of very high seizure likelihood, like if seizures happen in clusters, to stop a seizure cluster, or if you know that you often have a seizure, for example, when you have a high fever, or when you just haven't been able to sleep the night before, or whatever it is. So it's kind of an EpiPen for seizures. It's something to use in case of emergency, and many people can benefit from having a rescue therapy available. And I have a discussion about rescue therapy basically with everybody that I see. It used to be that you either would take a rescue therapy by mouth and it would take a half hour to work, and that would be a very long half hour if you're anticipating a seizure. Or you would have to take it by rectum, which nobody really loves. You can get away with it in babies, but that's about it. So we are very fortunate that just in the last year and a half, we have many options that are much more easily administered, either by squeezing in the nose or by just putting it under the lip. Nasal midazolam or nasolam, nasal diazepam or Valtoco, those are both nasal, or under the lip is buccal clobazam or sympazam. So those are all now available, and they work in about 10 minutes. And under development is this little device right here, which is actually a rescue inhaler, which I know my friends watching know very, very much about, because they were involved in the trial that showed that this actually can work in less than 2 minutes, and actually might be able to stop a seizure in its tracks. So we're looking forward to the next study of that, which hopefully will come very soon. From anti-seizure drugs to anti-epilepsy drugs, we talked about the difference between the two, that anti-seizure drugs don't stop the cause of seizures. And, if we know what causes the seizures, which we don't always know, but if we did, maybe we can treat the root cause and lead to disease-modifying treatments. And that's called precision therapy, treating precisely the disease that the person has with a targeted drug. Sometimes that can be done by correcting pathology or problems that are caused by mutations in genes. And there's some approaches to that. My example down here is that we all, if you look at DNA, we have 2 copies of genes. And in some conditions, we have a good copy and a bad copy. And the bad copy is making bad protein, and the good copy is making good protein. And now we have these things called antisense oligonucleotides that can basically eliminate the bad messenger RNA that gets made by the bad gene. And that messenger RNA is sort of like bad instructions to make bad protein. You get rid of that, and the good gene can make its good protein, and you can, actually reverse the course of a disease, which is really nice. Another example is tuberous sclerosis, which is another genetic disease that is caused by a mutated gene, either TSC1 or TSC2, which causes sort of runaway growth of cells because of a problem in a pathway in the brain called the mTOR pathway. We think that the mTOR pathway may actually be involved in a lot of epilepsies where there's just runaway or abnormal growth. And everolimus, which is already available by prescription, normalizes this pathway, so it basically counteracts the problem from this bad gene, and now is a targeted therapy for seizures associated with tuberous sclerosis. So these are just two examples, and we need more, and we're going to get more. One by one, we're going to get there. This is my little, and now for my little commercial about science. Science recently has come under a little bit of attack. Not in Hawaii, I'm sure. Everybody believes in science in Hawaii. Isn't that true? But one of the reasons that people don't believe in science, maybe, or have questions about science, is that people believe that science is truth, that a study should give you truth. But in reality, one study provides one truth in a population that has been treated one way over a specified period of time. So, maybe, this drug works in this group of people, but it might not work in another group of people. So I liken that to this little example. So when I do a single trial of a seizure medicine, it's like asking the question, can a bus, that's the drug, get me from New York to Philly? It's something I do a lot, so it's something I think about. And the answer might be, yes, you can get from New York to Philly by bus, and it's going to take this amount of time. This is how many times the bus crashes. This is what it costs to get on the bus, right? But that's not the question. If you have epilepsy, that's not the question that you're asking. The question is more like, how should I get from New York to Philly? What's the best way to get to New York to Philly? I don't have only the bus to think about. I have the train, I have a car, I have a plane. Which of those is the best option for me? And I might be different. Maybe not everybody can take the bus, because it would take them like 4 hours to get to the bus station, and there's no bus to the bus, in New York. Or they can't take a plane because they're claustrophobic, or there's some other reason. Maybe they only have enough money for the bus and not for the plane, and so on and so forth. There's a million reasons. So we want to know the answer to how should you, John Doe, get from New York to Philly, and a single clinical trial can't answer that question. So how are we going to get to that kind of answer? And, that goes along the lines of what we know when a drug is approved and what we don't know when a drug is approved, that we have to learn after a drug is approved. So we have two things going on at the Epilepsy Foundation that we hope will help us come closer to these answers. One is called Eden, which is the Epilepsy Digital Experience Navigator, and the other is ELLIS, which is the Epilepsy Learning Healthcare System. So what does Eden do? Eden is an aggregator of information. So what I say is, imagine that every person with epilepsy, maybe you can't donate $1,000 to the Epilepsy Foundation, but what if you could donate your journey? What if you could donate your experience about, I tried these drugs, they worked for me, they didn't work for me, and this is who I am, and this is what kind of epilepsy I have, and these are all the drugs I've tried before. But you could do it in a very simple, straightforward way that's not going to take you a lot of time and effort. So this is a platform that you sign up for, you give your permission, and if you give your permission, then your seizure diary anonymously can go into the great, overhead cloud of data about people with epilepsy. It can also take information right from the health record about you, what drugs you're on and what other conditions you have. And then a big algorithm in the sky looks at all of these people, hopefully tens of thousands of people, and starts to separate out, this is working for this group of people, it's not working for that group of people, or there's an early sign whether it's going to work or not, or whatever. Another thing that can be connected to this platform is devices like Fitbits. I wear a Fitbit, And every morning I can look at my phone and it will tell me how many hours I slept every night. And it will tell me how many steps I walked. Now imagine if, tens of thousands of people are donating their Fitbit information, which you can do just by connecting it on the back end, then you never have to do anything else. And then, like, after looking at thousands of people, the big algorithm says, look, when people go on this new drug, they're walking on average 2,000 less steps every day. Maybe they're a little slogged down by this, or maybe they're walking faster, maybe they're taking more steps every day. Or, this is the way their sleep is changing. They're sleeping more or they're sleeping less, and so on. So this is how we can learn without in any way bridging people's personal privacy, but using their data to make greater learnings. And then the other thing that the epilepsy is trying to do is, through various means, accelerate new devices for this kind of tracking and other things into the marketplace. And the epilepsy learning healthcare system is 13 epilepsy centers who are working, it's called co-production with patient family partners, trying to make every patient encounter in those epilepsy centers count. Every encounter should count so that we see what works and what doesn't work. And this is a circular, we study what happens, we make a new plan, maybe we have to change something, we try the new plan, it either works or it doesn't work, and it iterates and iterates to better and better and better intervention by doctors, best practices that then can be shared between centers. And going back to what we're doing with the Eden platform, which is the data aggregator, not only do we want to, learn the great truths from all of this data, we also want to give back information to people by being able to visualize the data for them. So the data is anonymous in the big database in the sky, but for the person who donates the data, there can be a chatbot that actually gives you some learnings like, hi, John, I see you're not sleeping so well. Do you want some information about sleep? Do you want to know whether the drugs you're on can cause sleep problems or something along those lines? And obviously, all of these things, we're going to need people with epilepsy to tell us what we should say and what we shouldn't say and what people want to hear and what they don't want to hear and so on. What can we learn from this, aggregated data? Well, here is something from a prospective observational study we're doing right now with many, many centers, looking at people who were started on with focal epilepsy on drugs for the first time. And this is what's called a survival curve. It doesn't mean that they died. It means how long did they decide to stay on the drug? And they might have stopped the drug because they weren't feeling well, or they might have stopped the drug because the drug wasn't working for them. But this line down here is levetiracetam. And let me tell you, or Keppra is the other name. And let me tell you that Keppra was started as the first drug in 2/3 of people, 2/3 of people. And this is what we call a group of drugs called sodium channel blockers. They're somewhat older drugs, lamotrigine, oxcarbazepine, carbamazepine. And guess what? The drug that started in 2/3 of people were dropping off of much, much faster. I see that you're nodding your head because it probably happened to you, right? I get a lot of that when I show this slide, that now we can go back to doctors and say, hey, guys, maybe it's not such a great idea to start everybody on levetiracetam from the get-go. It may be easy, but it may not be good. So this is the kind of thing that we can learn and then go back and do better the next time. And in addition, the Epilepsy Foundation is looking very future forward. And we have found that in some cases, if you track your seizures very well, and this is another thing hopefully Eden will let people do, that you can start to see patterns come out. And the patterns can be so consistent over time that you may be able to eventually predict, just like a weather report, whether you're in a period where a seizure is likely to happen or a period where a seizure is less likely to happen. And, as somebody just explained to me, it's like if, something happens every third week on a Thursday, you probably won't notice a pattern unless it's pointed out to you. And also time of day. And so this is starting to get predictable enough that actually it may be up to 80% good prediction, just like the weather report. It's not going to be always correct, but it can get pretty good. And it can also be more predictable when you add things like resting heart rate. And, there are new devices that are coming out that can even record EEG. So as we're getting more and more and more of this information together, maybe we can't stop your seizures, but if we could predict your seizures, then that would go a long way to letting you have a normal life. So we're trying to work towards my seizure gauge, as we call it. So that's all I had to show you for today. Hopefully it gives you a little bit of hope for the future. I think these things aren't decades away. I think they're years away. So I'll leave you with that very positive thought. And thank you very much for your attention.